Hi all, I'm Dr. Ragasudha working as a senior gynecologist in Birthright by Rainbow Children's Hospitals, Vishakhapatnam. I'm also an executive member of Safe Motherhood Committee, FOGSI, India. So I would like to discuss the most important topic, stillbirth, which is essential to be discussed. As a gynecologist, I have witnessed the magic of birth with countless couples. At the same time, I have also walked alongside families through some of their darkest moments, seeing the joy of pregnancy turned into grief. Stillbirth is definitely a heartbreaking experience for the family to endure and bear, and it is time to talk about this topic openly. And in the next few minutes, I would like to discuss stillbirth in the form of question and answers. So, very few questions for you, just five. So, they are: what is stillbirth? And what are the causes of stillbirth? Can stillbirth be prevented? And how quickly a dead baby should be delivered out? And what is the risk of recurrence? So, this format is to make you understand more clearly and with comprehension. So, what is stillbirth? Stillbirth is whenever a baby inside the uterus dies after 20 weeks of pregnancy. If the baby dies before 20 weeks of pregnancy, we call it as miscarriage. Miscarriage is also traumatic, but compared to miscarriage, stillbirth is much more traumatic because this usually happens towards the end of pregnancy, after 28 weeks, or sometimes even just few days or hours before the onset of labor pains or birth of the baby. And its incidence is, as I've already shared, 1 in 250. Out of 250 pregnant women, one can have this danger of having a stillbirth. And the common question that all the couples ask is, what could have caused this stillbirth? How can we know the cause for this stillbirth? Every couple would like to know the cause for this stillbirth. So the truth is, though we investigate thoroughly, it's not possible to ascertain the cause in all cases of stillbirth. Maybe in two cases we can find the cause for the death of the baby inside the uterus. So through thorough history, examination, and certain investigations, in at least 40 to 50% we'll be able to find the cause. And the most common causes are placental disorders, where the blood supply happens and sometimes it can be blocked or impaired, which can result in reduced transfer of oxygen blood to the growing fetus, which can result in death of the fetus. And sometimes the defects in the fetus, as well as certain genetic disorders, can cause death of these fetuses. Infections can also result in an accident like this. And most commonly, medical disorders in mothers like hypertension, uncontrolled diabetes, certain autoimmune disorders, and some other medical problems can also cause stillbirth. And the third question is, can this stillbirth be prevented? Definitely, in most of the women, stillbirth can be prevented if they are under antenatal care right from the beginning. So I would like to stress one more point here, that even before the pregnancy begins, it's always good to consult a doctor for pre-pregnancy counseling to see whether everything is optimum with your health to carry a baby and to bring forward a baby. Especially like diabetes, anemia, hypertension, and certain other medical problems which can be corrected, should be corrected before you plan pregnancy. So pre-pregnancy planning plays a very, very vital role in having a very healthy and safe pregnancy outcomes for both baby as well as mother. And the second thing, so after a woman conceives, so if you begin your antenatal checkups right from the beginning, so in the first trimester itself, we do a scan called NT scan. Along with that, we also do a blood test where we assess the proteins that are released from the placenta. So with these two, NT scan and the various other parameters that are looked at at this NT scan along with this biochemical test where we assess the proteins that are released from the placenta. We'll be able to know the risk of mother developing hypertension and risk of baby developing growth restriction, and not only these two risks, the other risks of baby having or developing other chromosomal abnormalities like Down syndrome, Edwards, Patter's. So all these can be known. So if risk of hypertension is more or risk of baby developing growth restriction is more, we put them on low dose aspirin right from that gestational age till 36 weeks of pregnancy, which will prevent these things from happening in most of the women. So this is how it can be prevented. And taking good control of sugars. If a woman has diabetes, and controlling hypertension and timing delivery at the right time, at the appropriate time, will also reduce these mishaps from happening. And the fourth question now is, most of the couples, they want and they become very anxious once they know that baby inside their womb has died, and they want the baby to come out immediately, and they even think that baby would be able to be resuscitated back to life once the baby comes out. So once the heartbeat or the activity stops, that's it. So baby cannot be resuscitated again, cannot come to life. So that is one thing. And the second thing is, it's always better to avoid cesarean section. So vaginal delivery is recommended in these women because they can be able to go back home quickly, and they can have very quicker recovery, and the risks of future problems and future pregnancies can also be reduced. And sometimes baby might be needed to be delivered immediately, as in the case of abruption where the placenta gets separated from the uterus prematurely, and if baby is not delivered within a short time from this accident, so mother can develop certain complications like bleeding disorders, hemorrhagic shock and all that. So basing on the condition and situation, if C-section is required, it will be done in case of abruption and other complications in order to safeguard the health of the mother. But most of the times the recommended mode of delivery is vaginal delivery. And the last question that I would like to address is the risk of recurrence. So they become very anxious once this happens in the next pregnancy, what would happen. So the good news is that though the risk of recurrence is high, it can be seen in around 2.5% women. When the baseline incidence risk is only 0.4%, it increases by a many number of times to 2.5%. But still, in 97.5% women can still have a very healthy pregnancy with a very good outcome. So it is not at all necessary to panic in these situations, because you always have time to go forward. And it always humbles me whenever I see these couples go through all these problems so silently with a lot of strength and courage to face this, and also to endure everything that comes along with this, and walk along and have their future pregnancies with a very good outcomes. Thank you so much for your patient listening. Have a safe pregnancy. Thank you.